Good morning, everyone. We're going to begin today. So just one caveat, it's not going to be as fun as last time because we are talking about a very serious topic. So there may not be as many opportunities for chocolate tossing, but I'll still try to fit it in. But today we're going to spend some time talking about ethics, and it's really, really important because I think that when we think about sort of ethical considerations in the conduct of medical research or in epidemiologic research, we really feel like the pendulum is sort of like this, right? That there's a clear right and a clear wrong, and that everyone sort of understands and has morals and is ethical in the way that they will conduct their research. But actually the lines are blurry a lot of times, and so we have regulations in place to help us unblur the lines. And so I'm just going to today spend some time talking a little bit about ethics and how we prevent the wrong from happening in the research that we're conducting on a daily basis. And so this isn't going to be sort of a quick course in medical ethics. There's textbooks for that, and you can learn about the Hippocratic Oath and all that kind of good stuff and, sort of leaders in medical ethics. But we're going to really focus in on some ethical sort of considerations in epidemiologic research, beginning with the early protections of human subjects. So we're going to talk about the events that led to the Nuremberg Code and the Declaration of Helsinki and what those two things are. We're going to talk about some examples of unethical conduct within the U.S. So we're going to talk about the Tuskegee syphilis study, human radiation experiments, the events that occurred at the Jewish Chronic Disease Hospital and the Willowbrook study. And then we'll talk about the response to some of these examples of unethical conduct. And highlight the Belmont Report and the Institutional Review Board, and then we'll talk about what is responsible conduct in medical research. So we'll talk a little bit about HIPAA, conflicts of interest, inclusion of women and ethnic minorities in studies, and then some special considerations in the face of genomics research. So before there was the Nuremberg Code, there were the Nazi medical experiments. And these experiments were conducted, these are sort of the atrocities associated with World War II. And between 1942 and 1945, these experiments were conducted in 8 concentration camps that you can see as the squares on the map throughout Greater Germany. And so there were sort of upwards of 7,000 individuals that were victims and unwilling participants in these experiments. And so there were 3 classes of experiments that were conducted during this time. The first class was to facilitate the survival of military personnel. So there were freezing experiments, and they really wanted to figure out sort of how to prevent hypothermia among their military personnel. So those experiments were designed to test ways to improve their survival. The second class was designed to develop and test pharmaceutical and treatment methodologies. So individuals in these concentration camps were injected with immunization compounds to try to figure out some prevention for malaria and typhus and tuberculosis and other infectious diseases that were highly prevalent during that time. There were also bone grafting experiments that were done under this second class of experimentation. And then the final class was really sort of designed to advance racist ideology, right? So they had experiments that were designed to see if people of different races responded differently to different infectious agents. They wanted to see if they could conduct mass sterilization of races that were considered inferior. So that sort of third class was all designed to push forward their agenda in relation to their racist ideology. Yeah. So they basically just conducted these bone grafts, and I don't know exactly what they were trying to do. I'm assuming that it was in relation to some kind of treatment benefit for someone else, but I don't know exactly what they sort of were able to extrapolate from bone grafts. So, I don't know much about that sort of class of experiments. So these are some images from the war crimes, and this first image just shows some medical personnel, and they're conducting an experiment on a prisoner in a concentration camp. I can't tell if they're injecting him with something, maybe not. So I'm not exactly sure what they're doing to him, but nonetheless, it wasn't good. In this next image, we see a prisoner, and he's in a compression chamber. And this particular study was designed to, or experiment was designed to determine the altitude by which the aircraft crewmen could survive without oxygen. And this particular individual sort of went on to lose consciousness and die. And this image just sort of highlights the fact that these experiments were also conducted in children. I don't know if you guys are familiar with the Angel of Death or Joseph Mengele, I believe is how you pronounce his name. And basically, he conducted experiments. He preferred twins. He would do things like see if he could change the eye color of one twin based on injecting chemicals, trying to see if, sort of the result of amputations and shock treatments and a lot of other inhumane experiments were conducted on these children. And so eventually, these crimes were brought to trial, and this is the Nuremberg war crime trials. It's the doctors' trials that were conducted in 1946 to 1947. You see images of the trial in the photos, and basically there were 22 men and 1 woman who were brought to trial for unjust medical conduct. And there were 85 witnesses, 1,500 documents presented, and 16 of the individuals were convicted either to death or long-term imprisonment, and 7 were actually found not guilty. So the results of this trial are the Nuremberg codes, and this is sort of named after the location of the trial. And the Nuremberg Code was developed in 1947, and it represents the standards for judging physicians and scientists. So basically, throughout the trial, they had to sort of go through documents and figure out the criteria in which they were going to find individuals guilty or not. And so the criteria that they developed throughout the trial later went on to inform this particular code. So it represents the basic principles of ethical conduct in human subjects research, and it became the prototype for other later codes that we'll talk about in a minute. So to summarize the code, it talks about voluntary and informed consent of all human subjects is mandatory in research, that experiments should yield some fruitful results for the good of society, that experiments should be based on animal experiments first and knowledge of natural history or disease under study, to avoid unnecessary physical and mental suffering of injury, and that no experiment when an a priori reason to believe death or disabling will occur should happen. It also went on to mandate the degree of risk should never exceed that determined by the humanitarian importance of the problem. That can sort of be a gray area there. Proper preparations and adequate facilities provided to the protect subjects, that experiments conducted by scientifically qualified persons should happen, so these persons should be certified or well-trained, that subjects have the right to withdraw at any time, and that experiments must be terminated if continuation is likely to cause injury, disability, or death. And so then the Declaration of Helsinki in 1964 sort of represents the international acceptance of the Nuremberg Code. And this was written by the World Medical Association, mostly towards physician conduct. And it highlights the same principles of the Nuremberg Code, but it also makes distinctions between clinical research and non-therapeutic clinical research as well. And so now we'll spend a little bit of time talking about some examples of unethical conduct in the U.S. And first, we'll talk about the Tuskegee, syphilis study. And this was a study conducted between 1932 and 1972. And I'm always surprised at sort of the time span at which the study was conducted. And, sort of the 70s, I was born in the 70s, so it's very disturbing thinking about sort of how recent these kinds of atrocities were going on. The study was designed to examine the effects of untreated syphilis in black men. It's called the bad blood study because these men were told that they had bad blood. And so that's why it's labeled the bad blood study. So just a little bit about syphilis, because we forget about syphilis, right? Because it's an untreated, it's a treated or curable infectious disease. But basically, we know that it's transmitted person to person or mother to fetus, that there are these 4 stages. In the later stages, the latent and tertiary phase of the disease really leads to, sort of dementia. So basically, your body just fails you at some point. It leads to paralysis and death. So when untreated, it really is very serious and it leads to death. And we don't have a problem with it today, but in 1970, we were conducting these experiments on black men. So there were 600 black men who were enrolled in the study. 399 of them were cases and 201 of them were controls. And the Tuskegee syphilis study was supposed to be the prospective study to follow the Oslo study. So there was a prior study that actually documented the manifestation of syphilis, but it was done retrospectively. So these are the retrospective accounts of what happened in men with, mostly white men, with syphilis. So this was supposed to be the prospective study to sort of follow men over time as they develop syphilis and to look at the manifestation of syphilis. So I mentioned it began in 1932. What happened in 1945? Someone. I can't hear. Penicillin. Who said that? Short. So basically, effective treatment for syphilis, penicillin, developed in 1945, and you can see that the study still went on for 27 more years. So how could this happen? How could, in 1945, there's a cure, and men go on to continue 27 more years of being untreated, dying, sort of, who were these men and why was this able to go on for so long? Anybody have any ideas? Yes?
They were in rural areas and doctors made sure that
So they were vulnerable. Ooh. And so are you, sorry. Sorry about that. So they were vulnerable in different ways. So these are just some images. You can see them sort of recruiting men in the fields. The woman showed is Nurse Rivers, who was a black nurse and very instrumental in reaching out to the men and, sort of being this caretaking figure that appeared to be very concerned for their needs. And that was probably the reason why they also were able to recruit the men and to keep them in the study for as long as they were followed. But more importantly, the men were poor and they were illiterate. Most of them had never been to a doctor. And they provided many incentives to the men that made the study appear to be more attractive than it was. So there were free physical exams and free rides to the clinic. Hot meals were provided on exam days. There were free treatments for other minor ailments. And there were also burial stipends provided to the families of the men. But if we think about 1945, why then weren't, sort of men hearing about this cure from other people, other doctors? Does anybody have any idea how this was able to sort of go on to this degree, to this magnitude for so long? Yes.
Well, this is the South during the time of the approach. Legally, according to local law, because these men were second class citizens.
Right. So these.
Provided access to information. I'm sure some colleagues argue that part of the question is because it was sort of treated that.
Mm-hmm. Exactly. I can't reach, no way for sure I can get back there. So feel free to get chocolate at some point. Yes.
I wonder if they can just lie to them when the guys were like, if they referred, there was a cure with an total, we're going to do this here, bad blood.
Well, there's different accounts of things. I mean, so for example, one thing that I know for sure happened was that the investigators in this study would go to other local clinics and say, don't work with these men. We're already working with them in this study, but they didn't disclose that they were untreating them. So that was something that definitely happened. So even though there were, so they were second-class citizens, but if you go into another treatment facility, by law, they have to give you treatment, but they were told these men are a part of our special study, we're treating them, et cetera, et cetera. So that was another way that it was able to happen for so long.
Is the study rationale choice for only black men?
I think it ties into this belief of who is valued and who is not. And what we see oftentimes is that it's the most vulnerable of society that are often the victims of these kinds of crimes, right? So black men who are poor and illiterate, children, mentally retarded, elderly, compromised individuals, right? So it's the individuals that are sort of oppressed in some way, are not empowered to advocate on behalf of their own health. And so that's why we see the majority of these things happening in those populations. Yes?
What was the justification for the study after penicillin was discovered in 1945?
Because they wanted to understand the manifestation of untreated syphilis. And I think because we didn't have regulations in place, we were allowed to say, oh, I just want to see what's going to happen. I just want to know. And we didn't have to be concerned with the fact that there was, sort of beneficial treatment, that we could save lives, that lives were important. We didn't have any of those regulations at that time. So they were allowed to just say, I want to know. I'm curious. And so they did so. So the study conclusions were that morbidity is worse in untreated males. Woohoo, right? I think we kind of knew that. That the cardiovascular and central nervous system were compromised in the late stages of infection. These were things that were already documented with the Oslo study. Oh, I'm sorry. Yes.
I just want to mention that this study was not just happening in the South, it was also happening in Guatemala at the same time.
Really?
Yeah, and actually the Obama recently had to apologize to the president of Guatemala for something that happened basically over 50 years ago.
Yeah.
Brought some of the survivors in and apologized to them. Like there's women who survived.
You mean from Tuskegee or from? Oh, yeah. I'm going to talk about that actually. Yeah, Clinton did. Yeah. So the problems with the study obviously were that there was no informed consent, no full disclosure, that patients were prevented from receiving treatment. I told you how they were going around to other facilities and telling them not to treat them. That patients in some cases were injected with syphilis without consent as well. So there was a lot of cover-up and activities that were going on that were problematic. And yes.
Did they look to recruit initially people with syphilis already, and then it was like they didn't get enough, or were the majority injected, or?
No, so I couldn't come across sort of explicit documents talking about why and under what circumstances men were injected with syphilis. I know that in the beginning they really just wanted to have both arms so that they could compare the progression in men with and without. But as far as why they were injecting men, I don't know. Yes? That's a good question. And I doubt it. Yeah.
How is it that the study was able to continue when the code and declaration were in place?
Because those were international codes, and we had yet to adopt anything similar in the U.S. And so we'll talk about what it led to in a minute. So this was an article that was published in the American Journal of Public Health in 1998 that basically just talked about the neglect and the lessons learned from this particular study. And you can see that the author talked about how between, sort of during the years of the study, there were at least 16 articles that were published from this study, including this specific journal, the American Journal of the Medical Association, the New England Journal of Medicine, all top public health journals that we read and journals in medicine that we read today. So the study was not a secret. The rationale is that its rationale, its subjects, and its failure to treat even after the advent of penicillin must have been common knowledge to many public health professionals, right? But people just didn't care. And so it goes on to say that to the best of my knowledge, no article, editorial, or other statement condemning the study appeared in medical, public health, or social science journals until after the Washington Star exposed it in 1972. This 40 years of silence included even the National Medical Association and its journal. And so then the author goes on to say, how can we explain these many years of silence and the decision of Public Health Service to continue the study in the face of egregious wrong? Does the silence tell us something about our own buried biases and stereotypes that operate often without our conscious knowledge to influence our behavior and protect ourselves and our professional image? All right, so that sort of sums it up in a nutshell. And this is what you were talking about, right? So this was Herman Shaw. I think this was in 1997 when he was brought to the White House, and there was a formal apology by Bill Clinton. I think he went on to die later in 1999. And so his words were that we were treated unhuman at all times. Nobody knows what we went through except those of us who are living participants right today. So next we have the human radiation experiments, and these were conducted between 1946 and 1974 by several U.S. agencies. There were experiments on humans involving radioactive materials, and it involved branches of the military, so it's highly classified. It's hard to get accurate accounts of exactly what happened. But basically there was a report, there was an advisory committee sort of charged to review these experiments, and they found 81 examples of pediatric research projects that were conducted within this stem of experiments, that there were non-therapeutic nutritional studies at a school for mentally handicapped children, so again talking about vulnerable populations here, that consent was sought without telling the parents that radiation would be used, and that children were induced to participate even if they refused. So we can see a lot of violations, and some of the language around the violations and the types of violations around informed consent and full disclosure are going to go on to be a part of our regulations and what our institutional review boards do on a daily basis. So they also found radioactive iodine given to mentally handicapped children, again, vulnerable populations. They were also using cancer patients, again, vulnerable. There were several thousand government-sponsored human radiation experiments and hundreds of intentional releases of radioactive material conducted during this time. And again, part of the atrocity included that they were not notified of the experiment in some cases. They were not given informed consent in some cases. They were not fully informed of the potential health consequences. They were vulnerable populations. So again, you see the poor, the elderly, the mentally handicapped, infants, prison inmates. And some experiments served no apparent therapeutic medical purpose, right? So for no good of society in this situation. Next, we have the Jewish Chronic Disease Hospital, and these atrocities occurred in 1963. There were 22 chronically ill patients without cancer, and they were ejected with live cancer cells. And their rationale was that they wanted to learn if foreign cancer cells would live longer in debilitated non-cancer patients than in patients debilitated by cancer. So they were just curious. Subjects, again, were not told that they were being injected with cancer cells. The doctors claimed that they did not wish to stir up any unnecessary anxiety in these patients who had phobia or ignorance about cancer. Patients were not in a physical or mental condition to give valid consent. And then finally, we had the Willowbrook study, which was conducted between 1963 and 1966. And this was in the Willowbrook State Hospital in Staten Island, New York. Again, vulnerable population in this case was children with mental retardation. And the goal in this particular study was to study the natural history and progression of hepatitis when left untreated. Again, leaving individuals untreated because we're curious as to how it manifests. And in this particular study, they found sort of two strains of hepatitis, right? So they found sort of the hepatitis A and B, the shorter versus the longer incubation. One is more communicable than the other. They also found sort of the agent that provided some protection against hepatitis. And the rationale by the doctor who was either the principal investigator or on the study team was that disease transmission was inevitable and that they received parental consent in this case. So this was the sample letter of informed consent that they gave to parents. I'm going to read it and then I'm going to ask you what are the problems with this particular statement. So it says, we are studying the possibility of preventing epidemics of hepatitis on a new principle. Virus is introduced and gamma globulin given later to some, so that either no attack or only a mild attack of hepatitis is expected to follow. This may give the children immunity against the disease for life. We should like your child to give your child this new form of prevention with the hope that it will afford protection. Permission form is enclosed for your consideration if you wish to have your child given the benefits of this new preventative therapy, I presume it said. Will you so sign the form, right? Signify by signing the form. So what's problematic with this particular letter? Yes. No full disclosure. Oops. What else?
It does make clear that some children are not going to receive this preventative.
Yes. Sure. Yes.
I also feel it's deliberately written in such a kind of wordy way to minimize full understanding of what's really happening.
Absolutely. And then another problem is that it's not expressed in this letter, but we're talking about the days where no one knew what to do with mentally handicapped individuals, and so they were locked up. And so parents actually wanted their kids in these facilities because they didn't know what to do with them. And so they also sort of had a form of coercion where they were telling parents, we can give you a spot, we know there's a waiting list, we can bump you up if you provide consent to have your child participate in this study. So that also was done. So basically all of these violations, so Tuskegee and the Jewish hospital and Willowbrook and the radiation experiments all led to a response in the United States to these atrocities. And so Henry Beecher actually published an article and it was Ethics in Clinical Research in the New England Journal of Medicine in 1966. And the question that he posed was, would American researchers meet the standards of the Nuremberg Code, right? So we already had this code. We also had the Declaration of Helsinki. Why was it not adopted within the U.S.? And so he found 50 examples of unethical research, 22 of which he examined in detail, and found that only two of them mentioned informed consent. And the conclusion was that there were unethical procedures that were being conducted within the U.S., and he recommended that at the very least we adopt informed consent policies, risk versus benefit policies, and that no publishing of this unethical research.
Why didn't we why didn't we participate in Nuremberg, or is there absolutely not?
So the Declaration of Helsinki is supposed to represent everyone, right? So there were members of the U.S. who were a part of the World Medical Association that were responsible for this particular document. And so we were fully aware and arrogantly operating as if we were, sort of acting within the rules set forth within the code, but we weren't. So this particular article was sort of the final straw, and in 1974, there was a National Research Act and the U.S. National Commission of the Protection of Human Subjects of Biomedical and Behavioral Research. That commission met between 1974 and 1978, and their goals were to identify the basic ethical principles that should underlie the conduct of biomedical and behavioral research involving human subjects, and then to develop these guidelines, which should be followed to assure that the biomedical and behavioral research is conducted in accordance with these basic principles. And so this led on to the Belmont Report. And you can see the report here. And there are basically three sort of underlying principles of the report. The first is the respect for persons, so that autonomy of individuals is respected, that persons with diminished capacity or autonomy are entitled to protections as well, so that we can no longer take advantage of these vulnerable populations. Beneficence is that the respect to respect persons' decisions, and to protect them from harm, to maximize benefits and minimize harms. Is also under this particular principle. And then finally, justice, and that is that the benefits and risks must be distributed fairly throughout society. And so we make sure that the Belmont Report and sort of parts of the Declaration of Helsinki and parts of the Nuremberg Code are all practiced and conducted on a daily basis, and this is done by the Institutional Review Board. So how many of you know about the IRB, have had any interactions with the IRB, and have wanted to pull out your hair regarding the IRB? In this particular cartoon, talking about waiting for IRB approval, right? So we all know that we have to sort of like submit for approval and wait for months. So this is sort of illustrating that long wait. And this is a document talking about how, in fact, they can be very nitpicky. And, I'm in the process of an IRB application right now, and I have to respond to 20 comments on every little thing. But it is because the lines of, sort of that pendulum and how we think that we're always on the side of right, it can become very blurry. So they help us regulate and to ensure that we are protecting human subjects and that there is no unethical conduct in research. And so the IRB is really charged, and when you're writing your IRB sort of documents, you really have to talk about how the risks to subjects are minimized, how any risks are reasonable in relation to the anticipated benefit. You have to clearly state that in your IRB application. You have to talk about how the selection of subjects is equitable, how informed consent is sought and received from each subject, or by his legally authorized representative, and you have to actually submit an informed consent document. There's templates. It has to have specific language, full disclosure, the study title, the purpose of the study, how long it's going to be conducted, what are the risks, what are the benefits, how will they be minimized, the rights of the participants in terms of being able to withdraw from the study at any point in time, contact information if they have any questions, contact information to the Institutional Review Board of the host institution so that they can report any misconduct or any concerns they have, right? So there are a lot of regulations around what these informed consent documents have to look like. And what else do they have to do? So I've talked about sort of the technical things, right? It has to have sort of full disclosure and all these kinds of things. What else is really, really important in an informed consent document in terms of the way it reads? Yes. It has to be understandable, right? So we can't use all these big words. We like to use big words, right, all the time. And we like to use our fancy acronyms for everything, the HSB, the such and such, the Epide, the this. We want to use all these acronyms. You can't do any of that in an informed consent document, right? And I think they probably regulate it to something like a 3rd to 6th grade reading level, something like that. And so it has to really be understandable for the participants in the study. The IRB also, when appropriate, they call that the research plan makes provisions for monitoring data collection. So this will include what data you're collecting, what you're going to do with the data once you receive it, how it's going to be stored. It has to be sort of stored in locked file cabinets or behind password-protected firewalled computers, in a so-named individual's office, when you'll destroy study materials, how you will ensure the confidentiality of participants by using some kind of identifier and not any public health information of names or addresses or any other kind of information. That all has to be stripped from data that is shared sort of amongst the study team. And when some or all the subjects are likely to be vulnerable to coercion or undue influence, that there has to be additional safeguards included. And so one sort of real challenge and struggle, and there really is no consensus, is how much we should or should not compensate individuals into a study, to participate in a study, right? And so you have to sort of straddle this fence of compensating them for their time, but not unduly compensating them so that they would participate just to receive the compensation. And this is another example of where it gets really blurry. I mean, I've seen some studies where, you know, you can do something, get $75, and, you know, and the $75 for a college student who, you know, needs something or whatever is kind of like, yeah, sure, I'll go participate in the study and I'll get $75 and I'm good to go. Similarly, there are some studies where you spend so much time, right? So the burden on the participant is extreme, and they give you a $10 gift certificate to, you know, Safeway or something like that. And so then you think, we really aren't compensating individuals for their time. So there's a lot of sort of blurry areas in terms of what is the appropriate compensation and how you ensure that the compensation is not unduly persuading individuals to participate in the study. Does anybody else have any sort of comments or questions about any of that? No? Okay. So I talked about sort of what has to go into these informed consent documents, and how there are templates and regulations around what they need to look like. So then what does the responsible conduct in medical research look like? I mean, how do we ensure that we are operating responsibly? And you can see here in this sort of roadmap to responsible conduct, right, we highlight different things, right? We highlight that there should be no conflict of interest, that there are ethical limits to what we do, that we want to be impartial and we want to be accurate, that we want to have humane treatment of individuals. We have to seek out IRB approval. We have to ensure efficiency and that we collaborate with the appropriate individuals and experts in the field. Oh yeah, and that there's no misconduct over there in the right-hand corner. Lab safety is also represented there. So these are some of the considerations that are part of responsible conduct. And so the responsible conduct, right, so there's a certain amount that's regulated, right, from the IRB approval. There are institutional policies as well that help regulate the responsible conduct in research. And then there's some personal responsibility that we all have to take to make sure that there's no misconduct. And we have to make sure that we think about private health information and making sure that we protect individuals from any of this information being released. And the conflict of interest. Does anybody know what that's talking about? Sort of what is a conflict of interest? If I want to work or, you know, sort of conduct a study, how could I potentially have a conflict of interest? Yes? Right, so if there's some kind of personal or financial gain, then that's a conflict of interest. Ooh. Sorry. So what is a sort of classic case in which there's conflict of interest and it's sort of been very controversial? So that definitely can be a problem. So if you have family members who are enrolled, and especially, for example, if that leads to the unblinding of a clinical trial, so you want them randomized to the treatment arm and not to the placebo arm, for example, that's definitely important. Tobacco research is very controversial. The most controversial of all is research that is in collaboration with pharmaceutical companies, right? That is where the lines become very blurry with individuals who are receiving money from pharmaceutical companies to conduct research, and then pharmaceutical companies profiting from the, you know, sort of the results of these studies in terms of advocating for their new drug, you know, the thing that works better than all the others, et cetera, et cetera, et cetera. So now what is required is that you have full disclosure in manuscripts when you give a talk You have to list any conflicts of interest. So if you've received any money from pharmaceutical companies, if you've been paid for the research, you have to sort of document all of that in what you write and when you present. Yes.
Who double checks that someone is indeed disclosing their conflicts of interest?
Yeah. So that's a good point, and I think what often happens is it's the institution's responsibility, which means it becomes the school or dean's responsibility. And so, for example, as faculty, we do have to report yearly any compensation that we've received for any research. And so there's a document for that. But in terms of actually publishing a manuscript or presenting and whether or not I choose to disclose any information or not, it really is not regulated. So that's where the personal responsibility really becomes important. I mean, there have been examples of university lawsuits and against faculty who haven't disclosed and who have been taking money and double dipping, so like receiving money from the pharmaceutical company, receiving money from NIH, receiving, and banking that money. So there have been some examples of that. But short of that, there is not sort of routine.
Just very recently, I think maybe even this week, they passed a new law saying that they will post doctors if they receive any sort of compensation from device makers, pharmaceuticals. That's coming into effect. And some of you who are doctors might have already heard about that. But I think I just heard about it yesterday. So that's going to be something government somehow regulated. That's very new.
Yeah, and I mean, and the thing is, there's always ways around something. So what you're talking about, sort of, I don't know sort of how many years ago they actually sort of mandated how pharmaceutical companies can interact with physicians and what they are allowed to give and not give. And, sort of the initial language around that was monetary. So then a lot of shift happened where it was you can take them to dinner and you can get them a gift certificate to the spa or that kind of thing, so that there was no exchange of money. So the problem is that because we are not all as morally correct as we think, we're going to find ways to get the hookup, right? Everybody wants the hookup, and so we find the ways to do so. And so that's why we actually need more and more of this kind of regulation, because we can't be left to ourselves. We are sinners by nature. I don't know. So this is an example of another sort of example of misconduct in research. And this is a cartoon where this individual was saying, well, I didn't actually write the article, but, well, I didn't actually do the research either. And so there's a lot of, sort of on a smaller scale, there's a lot of issues around conducting research, relationships between mentor-mentees, so principal investigator taking advantage of students and using their ideas, exploiting the students, and claiming the work and the ideas of their students. That happens a lot. So there's a lot of sort of on a smaller scale kinds of considerations. Data is a big piece, right? So who has ownership of the data? Who has access to the data? One thing that's becoming really big now is how often you have to get informed consent when you want to do something different with the data. So, for example, you get informed consent to do one thing, and you then later on decide to do something else. And sort of until recently, individuals were just doing the other things and not going back to get informed consent. But now there's regulations around anything that you have done that is not in the initial informed consent document. You have to go back and recontact individuals and ask them for informed consent to do whatever the new thing is that you want to do. And so these are just some cartoons here that highlight some of the issues around data ownership and protection of and storage of biospecimens. And HIPAA is really important. It's the Health Insurance Portability and Accountability Act. It was passed in 1996 by the Department of Health and Human Services. And this is sort of an added step to ensure confidentiality and then also the security of electronic transfer of personal information. So now there are regulations around, not being able to just email the data set. Although I have to say it still happens all the time, but technically it's against the law to transfer any kind of information that includes private health information. And so you have to send the CD, and the individual has to request permission to use the data set. So there's different regulations in place now to make sure that this doesn't happen, although it still does. And HIPAA sort of outlines the fact that individuals have the right to receive notice when an agency or of an agency's private practices, to know that the agency will use its public health information only for treatment, payment, operations, or for certain other permitted uses that as required by law, that there is consent to and control of the use and disclosure of their public health information, that the access to their public health information, that they have access to their public health information, except for psychotherapy notes. They won't receive information on that. That they can request an amendment to their public health information. They can receive accountings of disclosures, and that file privacy complaints to an agency officer. I talked a little bit about conflicts of interest already, and this is sort of, again, talking about that whole incentive piece, right? So it says, and you'll get $50 per blood specimen, of course. That shouldn't affect your decision. And he's talking to a population of homeless individuals, so clearly that would in this particular cartoon. And then there's also some regulations around the inclusion of women and ethnic minorities. And this is really to sort of ensure that the benefit of advancements in medical technology and medical research are equally distributed throughout society. And oftentimes what happens is, for the longest time, for example, studies were being conducted predominantly on white men. And so now there's regulations around the inclusion of women and the inclusion of ethnic minorities in clinical trials, for example. And this is just sort of some legislation leading up to those decisions. These are the guidelines by the National Institutes of Health, one of the leading funder of medical research, that women and ethnic minorities need to be included in all human subjects research, that they also must be included in phase 3 clinical trials, that cost is not an acceptable reason for the exclusion of these groups. A lot of times investigators would argue that they're hard to reach groups, or that it would increase the costs beyond that of which they were granted based on the grant they received, and that no longer is an explanation for why you can exclude these populations, and that they're also to initiate programs and support for outreach to recruit these groups into clinical studies. And this is just sort of highlighting the reason in which these kinds of mandates were created. This shows between 2003 and 2005 the percent of individuals in a clinical trial of different racial and ethnic groups. And you can see, for example, as I commented, that 88.6% were white and 94.4% were non-Hispanic, non-Hispanic Latino, right? So again, indicating based on race and based on ethnicity that the majority of these studies are being conducted on whites. Yes.
I don't think that's right. But then at the same time, I remember like in the textbook of how race is not a biological factor, but for the socio-economic SES, right? So leading to race is not a determinant of health outcomes or risk. Your comment on that?
Okay, so if I understand you correctly, what you're arguing is that why do we need to ensure, for example, that ethnic minorities are included in trials if there's no genetic or biological component to race?
For that.
Okay.
I'm just asking if that's the argument that's out there that race is not a factor, then why should that matter? Of course, but I don't agree with that at all. So I'm just asking that question.
Right. So I think so for women it's clear, right? Because there are real sort of differences in anatomy and reproductive organs, et cetera, and making sure that we understand that there aren't any additional risks in women. Race is a little more blurry, and especially sort of with the advancement of the Human Genome Project and genomics research, what's happening is there is now sort of the ability to characterize individuals based on ancestry, right? So based on sort of country of origin, that is oftentimes proxied by race. So differences in admixture and country of origin are represented in a genetic landscape, if you will, by sort of this combination of, sort of a genome expression that you can see commonly occurring expressions in different racial and ethnic groups that are mostly mapping onto this sort of ancestry information. And so what I'm trying to say is that there is some genetic component, but we do know, and you are correct, that there is more variability between races than there are within races. So it's not that race is a proxy for genetics, but race is a combination of a small proportion of genetics and a bigger proportion of environment, social factors, context, lived experience, stress, all those kinds of things. But the range of studies, right? So in clinical trials, it has been controversial because we all know. Does anybody know about the Epide drug that was patented just for African Americans in terms of treatment for hypertension and cardiovascular outcomes? And the results of this were from a clinical trial, and it's very controversial on whether or not you can have a drug specific to one racial and ethnic group, and do we really have the evidence supporting that? And so there's a lot of people on one side saying that the evidence did not support that, and other people on the other side saying that the evidence did. So it's going to sort of evolve over time, and it's a sensitive issue, but everything matters. Genetics does matter. We can't say that it doesn't, but it doesn't matter the way that we think in terms of race. And I'll stop now just to say that there are also some considerations in human genomics research, and that sort of poses an additional set of ethical considerations, and that there are regulations being put forth around the use of genetic information in terms of health, in terms of employment, in terms of a variety of different outcomes. So we'll stop there.